Hello, it's my pleasure to be able to give a presentation on thyroid gland pathology today, and I'm going to do selected thyroid follicular lesions. So overall objectives is kind of what is the current management, what are the trends, what can we do differently, what kind of supporting data is out there, and what are some of the recommendations for management. And I always like to start out trying to drive a case because I think that is one of the most meaningful things for us to be able to do. And so here is a 15-year-old woman, or girl, I guess, who presented with an enlarged right thyroid gland lobe, and an FNA was performed on this kind of vague 4-centimeter mass with a lobectomy. So here is the specimen that I would like to drive. And here you can see multiple fragments of tissue. They are quite easy to see that there are multiple areas of lesional tissue as you look around. One of the things that is most interesting to me, first of all, is that there are a myriad of Sonoma bodies. So no matter where I look, I can see that there are multiple Sonoma bodies present throughout in the background tissue. And of course, one of the other things that immediately stands out is this very prominent chronic lymphocytic thyroiditis, which in the correct clinical context would, of course, be part of Hashimoto's thyroiditis. Then when I go into slightly higher power, I think you can see that there are multiple areas that show both papillary architecture to the lesional tissue, as well as areas that otherwise may show a little bit more of a squamoid appearance with the morial formation sometimes even present as it whirls around. What is quite interesting, though, is that all of these Sonoma bodies seem to be in dilated spaces and actually follow down the dilated space. One of the things that is helpful histologically is you'll notice these cracking artifacts, or chatter artifact, as we call it. That can be seen when there are multiple Sonoma bodies like this, because they actually drag across the tissue and will result in the fracturing. Again, here you can see a very nice example of a Sonoma body present within a lymphatic space. So with that in mind and driving that case, what would be your diagnosis? Now, I'm not going to have you guys actually do voting, but I think if you were to choose from the various selections that are available here, hopefully all of you will have at least chosen papillary carcinoma. And actually in this particular instance, it's an example of a diffuse sclerosing variant of papillary thyroid carcinoma. When one thinks about thyroid neoplasms just in general, I do think it is important to kind of put everything in context. And you can see that it is the single most common endocrine organ malignancy. So about 3% of all US new cancer diagnoses are comprised of thyroid tumors, being the 12th most common cancer type. As you can tell, the incidence is about 53,000 a year. And to put this in a different context, it's about one case every 8 minutes. So perhaps that's what you feel like when you are seeing patients. The death rate, though, you can tell is a very low number when you consider the overall percent of cases. Generally, it's a tumor of middle age, females affected much more commonly than males. And as you will notice when you look at this data, you can see that there is a 98.3% 5-year survival for all thyroid cancers. So this is probably one of the most compelling and interesting data points as one looks at this particular tumor category. It doesn't matter which race you're in either, it's still much more common in females than it is in male patients. Now, there has been a remarkable change in the incidence of thyroid carcinoma over the years. This is based on SEER data, and you can see that it goes all the way out to the most recent SEER data from 2018. But you can tell that there is this slow increase in incidence. And in fact, it comes sort of at a point of around the 1990s, early 1990s. I will say I actually started to work at the Armed Forces Institute of Pathology in 1994, so I feel as if I may have contributed to this increased incidence. However, what is quite interesting and the single most remarkable fact here, and that is you will notice that the death rate, so this is the black rectangle, the triangles at the bottom, and you can see that they have remained absolutely static. So what this tells me is that while we have had a remarkable increase in the detection and the identification of thyroid neoplasms, we have not really had any change in the overall patient outcome as far as death goes. So this means we're probably finding tumors that are not really clinically significant. And so if you think about the current management, either lobectomy or thyroidectomy, completion thyroidectomy is done, however, if any of the following are present. So really you can tell that if it's any one of these particular characteristics. So if you have known metastasis, extrathyroidal extension, tumors that are larger than 4 centimeters, if you have lymph node metastasis, positive margins, macroscopic disease, this is not microscopic tumor, but macroscopic multifocal disease. And then, of course, fully differentiated histology and lymphovascular invasion. Now, you can tell that this information is taken from the NCCN guidelines. And as you know, they put out twice a year. This happens to be from the one in October of 21. So what is interesting is if you flip this around and say, when is it that you would not do a completion thyroidectomy? And you can really see that no completion thyroidectomy is done only if all of these things are present. So you can really tell that there is a major bias and a major focus to doing a total thyroidectomy for these patients. And so when you think about overdiagnosis and overtreatment of cancer, trying to get a change in the overall pattern, you can tell that this has been discussed in the literature for quite some time. And this is an article from Lancet, even back in 2014. So let's first kind of put things in context as well about what it is that we generally see. And so if you think about the multinodular hyperplasia or goiter clinical appearance, multinodular goiter, nodular hyperplasia, adenomatoid nodules, non-toxic goiter, whatever name you would like to use. It really is something that affects about 5% of the population, although when you do autopsy studies, it's up to 50%. They can be compressing the adjacent structures. Usually the patients are euthyroid, and again, more common in females. This by itself does not necessarily equate to an increased incidence of cancer. So, you know, when you put things in context, let's go back, and I'm going to go back all the way to 1600. This is a painting by Caravaggio, and it's, you know, called The Crucifixion. However, that is not what I focused on. I went down to the bottom here, and if you look at this particular person, you can tell that they obviously have a multinodular goiter that is affecting the thyroid and can be quite large. And in fact, this particular illustration can suggest how really, really very large the goiters can become and clearly be quite clinically significant. There are so many different parameters that are utilized in the management of these patients, and you can really tell from this diagram and an algorithmic approach to how to manage patients with nodules. It really is quite complicated. One of the really good things, however, has been a standardization of the thyroid imaging findings through the TIRADS reporting system. And I do think that this is incredible. It gives a very standardized approach to what is being identified, both the composition, echogenicity, shape, margin, and a number of echogenic focuses, all put into what is going on with a particular risk stratification to say how likely are you suspicious for carcinoma. Now, one of the major things that I must point out with this system is it has been identified for each specific nodule. The nodules are sequentially numbered in the right and left in order to be able to identify at least 3 on each side. However, many times what is identified radiographically is not necessarily a correlation to what is seen histologically or pathologically. And so you may have a TIRADS that is low, in other words, a TIRADS of 2 without any suspicion, and then you do the thyroidectomy for some other reason, and there's papillary carcinoma. So this is because the imaging findings do need to be very specifically correlated back to the findings that we see on gross exam and histopathology, and quite often this is not done in a meaningful fashion. So here is an example of just a ultrasound. You can tell if you do Doppler flow, you're able to identify what's going on inside the actual nodule itself. And this is quite characteristic of what you see in adenomatoid nodules. By fine needle aspiration, lots of colloid in the background, usually having some sort of cracking artifact seen within it. Very low cellularity. You can see that the cells are quite monotonous in small groups of 6, 10, 12 nuclei present. In a non-follicular or maybe even just sheet-like distribution. And then, of course, lots of histiocytes are usually present as well. So if I were to show this particular image and say, just on this single high-power view, what would be your interpretation of this lesion? And I think many of you would say, oh, those are the nuclei of papillary thyroid carcinoma. Look at them, they're fantastic. You have colloid present in the middle. Well, I know that this is an endocrine organ lecture, but I'm going to try and fool you here for just a second and show that that is actually a high power field from a prostate core needle biopsy and has got nothing to do with papillary thyroid carcinoma. So all I'm saying is papillary nuclear features by themselves are not always diagnostic and need to be taken in context. Clearly, this is way out of context, but it does serve to prove the point of always recognizing where you are. So with that, though, the core needle definitely has taken on a major role in management, as we can see nowadays, but still it is a very limited sampling. So if you think about a core needle biopsy being about 1/10 of a millimeter across as a diameter, and then, measuring anywhere from a few millimeters up to 1.5 centimeters, you can tell that the volume of the gland that is being examined when looking at this is really quite fractional, and therefore it is a very small biopsy of what is otherwise a much larger lesion. So here, when we look at these histologically, I have two different slides. This is the first cut, and then these are multiple deeper levels that are taken at a later time. And I think you can see that the amount of lesion here is completely different than the amount of lesion here. And in fact, the tumor now appears in this deeper level of the core needle biopsy than what was seen otherwise. Also in this case, cracking artifact related to calcification has resulted in no lesion being present, whereas here you can see a lot of lesional tissue is now seen along with areas of calcification. So again, for us as a pathologist, we do try to get as many serial sections or levels on core needles in order to make an accurate assessment. One of the protocols we use is called a 1-5-12, which means 12 sections are cut. The first, fifth, and 12th is actually stained with H&E, and this leaves enough material in the intermediate sections to be able to do additional studies if they are required. Just a few comments about frozen. Intraoperative assessment has really gone down with the increase of fine needle aspiration, because while frozens are very specific, they are not very sensitive. And of course, an equivocal fine needle is going to be exactly the same thing with frozen, because it's also going to be an equivocal frozen. So when you do a frozen section diagnosis of follicular neoplasm deferred to permanent, it's not going to change the management intraoperatively at all. So in fact, if you look at studies across the literature, frozen changes the diagnosis or the management in only about 0.5% of cases. So the time required, the unnecessary loss of tissue, frozen artifacts, and increased costs really do make frozen sections unnecessary. And so it's probably a little bit easier to do touch preparations. As you consider frozen section, and when you think about it for a follicular patterned lesion especially, the tumor to capsule to parenchymal interface is where you really need to focus. And of course, you cannot submit that entire lesion during the time of frozen section, and therefore you're ultimately not going to succeed. So in general, if you have a fine needle that's called a follicular lesion, the specimen should just be sent in formalin. If you have a papillary carcinoma on fine needle, the specimen should be sent in formalin. And of course, if you have an FNA that's suspicious either for papillary or follicular tumor, again, the follicular tumor category is just going to go in formalin, whereas if it's suspicious for papillary, perhaps sending it unfixed to be able to perform touch preparations. So when I think about a multinodular hyperplasia, again, just going back to the gross, it's really the most common thing that we come across in thyroid pathology. So this is really the most common lesion, which is why I'm going to focus on it for a few moments, because they really are multinodular in their appearance. We usually ink the thyroids differentially in order to be able to classify either the left and right or which particular area of the thyroid gland we're looking at. But then a nodule just has a very complex appearance within it, lots of colloid being produced, so you get this kind of glistening quality to it. Yeah, you can see a very multinodular appearance, multiple nodules, all coalesced and seen adjacent to one another in this example. So architecturally, the histology of a nodule is really quite complicated as well, depending on the number of nodules that may be seen. Usually the surrounding parenchyma is not compressed, but certainly it can be, depending on how long it's been around for. The growth pattern is usually quite similar to the surrounding tissues, so having follicular architecture, sometimes having even a papillary projection here or there is certainly seen. The follicles will often contain abundant colloid, and of course degenerative changes are really quite common in this setting. So here are low power of a histology showing multiple nodules, right? I think you can see that there is a nodule over here, another nodule present here, several nodules coalescing and adjacent to one another in this space. A very large dominant nodule here showing degenerated changes in the center with large amounts of easily identified colloid. You will notice at the periphery that there can be accentuation of fibrous connective tissue. In fact, there's some fibrous connective tissue that is going in both directions here around a vessel. So they can mimic a follicular neoplasm. However, there are no smooth muscle-walled vessels present within this fibrous connective tissue, one of the findings that is helpful in separating it from a neoplasm. But again, with degeneration, internal fibrosis can be seen, and here you can see an acellular eosinophilic fibrotic material adjacent to the proliferation. Now, sometimes with either fine needle or just degeneration, you can see that there is a histiocytic component here with fibrous connective tissue, and immediately adjacent to these areas, it is not uncommon to have slight nuclear enlargement or even some nuclear chromatin clearing, but still that does not equate to the presence of a papillary thyroid carcinoma. From a cytomorphology standpoint, the degenerative changes are usually what are most easily identified with these very broad and simple papillary structures. The nuclei are located in a basal zone. They are round and regular with coarse nuclear chromatin, and of course, generally not having any nucleoli. Now, the artifacts of clearing and fixation can really be quite interesting to see, and I'm going to show you that here in a moment, just to show how they can be overcome. So, round regular nuclei, easy to identify, clearly having a bit of a hyperchromatic appearance in this example with a dense appearance to the nuclear chromatin. Papillary structures can certainly be seen, but each of these is quite a simple papillary structure where you can kind of draw a line around it without crossing over any other papillary structures. The nuclei tend to be lined up with one another. These happen to be in a kind of central zone of the cell, but they can be placed kind of anywhere, although it's when it's really jumbled that you begin to worry about the diagnosis of a papillary carcinoma. You will notice that there is a follicle within the papillary structure here, which is something usually seen in more benign lesions. One of the helpful findings, I think, is that degenerative change. And so you will see that there are numerous macrophages present in the space that is filled with colloid with some scalloping easily identified as well. But I think all of you will be able to see that there is, in fact, well-developed pigmentation present within the cytoplasm of the neoplastic cells. And that is one of the features that helps you to say this is more likely a benign lesion. So conceptually, if you think about it, this is a slow-growing process, and therefore it has time to absorb in some of the pigment or degenerated material, whereas in a papillary carcinoma or follicular lesion that is undergoing rapid growth, it does not have the time to do that, and therefore you don't tend to see it in the cytoplasm. So this is obviously conjecture, but it's one of the things that is quite helpful in being able to come up with the actual diagnosis. Now, you'll notice in this particular field, there is a suggestion that there may be some nuclear enlargement. There's even a suggestion that there may be some open or beginning to be clearing out of the chromatin. And so this may be a case where there is some worry or concern for papillary carcinoma. So let me show you an example like this. First of all, you can see that all of the nuclei seem to have this particular feature, and it looks like the nuclei are blown out. In other words, it doesn't look like a true intranuclear inclusion or a very fine, even nuclear chromatin distribution. This seems to be artifactual. And so in fact, when this tissue was reprocessed, you will notice that now on the reprocessed tissue, all of that artifact is gone. Let me show it to you on a different case. Here you can see that this particular tissue had also been frozen and then prepared in an incorrect fashion. But when it was reprocessed, you can see that all of those artifacts are again eliminated. So one of the things that can be seen in this is a fixation in high formalin concentrations, placing the tissue on a heating block for too long. So in other words, after the paraffin section has been cut and you're trying to melt off some of the paraffin before doing the additional staining, if it sits on that block for too long, it will result in the same type of bubble artifact. Now, I will say with the automated processes, this is less likely, although I can tell you that many times they may be placed on it and the cycle is not started correctly and they may still be hot from the previous cycle. And then one of the other findings is insufficient dehydration of the tissue. So in other words, the xylenes are no longer able to dehydrate the tissue correctly. And most frequently, this occurs when there is a kind of concept of being the last run of the day or the solution's not being changed frequently enough. So whenever I see that type of bubble artifact, I usually ask a person to perhaps run their thyroids as the first cases of the day rather than later on in the processing. And you will see that that particular bubble artifact is almost completely eliminated. So now we get to papillary thyroid carcinoma, and you may say, well, doesn't it look like you're just showing normal thyroid? Well, in fact, no. Here is the little microscopic papillary carcinoma, and I'm going to pull that up, and you can see that this has all of the very classic and characteristic features of papillary thyroid carcinoma. But it's one follicle. So clearly not going to be seen by imaging. It would never have had a fine needle aspiration. But when reviewed on histology, papillary carcinoma microscopic type can definitely be seen. And I have certainly seen tumors that are in this range of size result in metastatic disease to the lymph nodes. So they are not entirely innocuous, but in general still are something that if you look long and hard enough, probably 50% or more of every thyroid will have a microscopic papillary thyroid carcinoma somewhere within it. So let's talk about the new classification of the World Health Organization. Unfortunately, our meeting last year was entirely Zoom related. Here are all of the glitterati of the endocrine system, all sitting on their Zoom meeting, being able to come up with the criteria. So with that, let me actually try and just drive you through the sausage making, if you will, of how we get to a particular fashion. So let me hopefully be able to, get this to start. And for some reason, it is just not starting. Okay, so here we can begin. I wasn't sure what was going on there for a second, but we'll see if this works. So as you can tell, this is the endocrine and neuroendocrine tumors for the World Health Organization. The entire system is here on board, with beginning with the pituitary, going to the thyroid, extending down into the parathyroid and adrenal, tumors of the adrenal medulla, neuroendocrine tumors of the pancreas, mesenchymal tumors, hematolymphoid, germ cell, and metastases, all being separately classified throughout the entire endocrine organs. And then finally, the genetic tumor syndromes, specifically as they relate to their presentation within neuroendocrine organs initially. So let's go and look at the thyroid gland lesion just specifically now. And of course, we're talking about papillary carcinoma. So you can tell it's one of the largest systems here, 6,000 words, and we were a little below that. Lots of people involved in being the editors and authors for this section. So of course, each of these are heavily stylized. Definition and coding is included, with multiple subtypes being identified with acceptable terminology. Then the clinical features with epidemiology and etiology being considered. Pathogenesis, of course, is always a very complicated area and has some work still to be done, followed by the macroscopic and histopathology. Now, within the histopathology specifically, as you can tell, there's going to be coverage of immunohistochemistry as well, but then you get into all of the histologic subtypes. And we're using the term subtype rather than variant, because variant can imply molecular findings rather than just the subtypes. So you can tell there are a lot of subtypes. Cytology is clearly very important in thyroid gland pathology, and so there's a lot devoted to that as well, with diagnostic molecular techniques and then the essential and desirable criteria with staging and prognosis then carrying through. And you can tell that there is quite a lot about the staging. And then I'm going to quickly go through that there are just like a gazillion references, because this is one of the major areas that we deal with. So they're going to be a whole boatload of references that are identified. So let me just say that with the references, you can tell that they're all just PubMed IDs. So actually, if you go into the thyroid book online and you click on the same papillary thyroid carcinoma category, as you scroll through and get to one of the references, you'll notice that they are all hyperlinks. And so you can just randomly click on one of those hyperlinks and it will automatically launch into PubMed and actually show you the source material that was used to support the conclusions that are there. So it's a great way to use that particular model. One of the other things that's really great about this is you can tell there are a boatload of images. All of these images are easily accessible. And of course, here, if you click on one of them, this is a super large image, so it takes a little time to see, but now you're able to see the histology on a really large power, and you can tell that this particular image is quite large. One of the major breakthroughs, however, is virtual slides. So in this instance, you can see that there are 7 different whole slide images. And this means that you as an individual can actually go and drive that slide yourself. So let me just enlarge it and show you that you can just drive this as you like, right? So it is really a remarkable way of being able to, as a clinician, as a pathologist, no matter what it is, you can drive this in to the nth degree and actually see, oh, look, there are papillary nuclear features in this case of a solid papillary thyroid carcinoma. So it is one of the very fantastic tools with this particular edition that I think is going to be very, very helpful as we move forward with the classification system. So with the table of contents, let me just highlight it a little bit here so that you can see what the areas are. So you can tell that there are a variety of different subtopics. Let me just point out that the developmental lesions are there, follicular adenoma and oncocytic follicular adenoma, low-risk neoplasms, which of course cover the non-invasive follicular thyroid neoplasm with papillary-like nuclear features and hyalonizing trabecular tumor. And then of course the primary follicular-derived malignant neoplasms, then C-cell-derived tumors, mixed medullary and follicular C-cell-derived lesions, salivary gland type tumors as they affect the thyroid gland, and then kind of the thyroid tumors of uncertain histogenesis, which cribriform morular thyroid carcinoma and sclerosing mucoepidermoid with eosinophilia have been included. The thymic family of tumors has now been incorporated as a separate group too, with thymoma family and thymic carcinoma family utilized to encompass those lesions. The embryonal tumors have now been classified as thyroblastoma rather than specifically using malignant teratoma as a designation, although this is clearly still something that is in further development. One of the major breakthroughs too here is to completely separate out within the entire endocrine book all of the mesenchymal and stromal tumors, all of the hematolymphoid germ cell and metastases. So this means that there is a particular chapter on metastasis for each organ, but it is not specifically within the thyroid gland. And the same thing, a lymphoma of the adrenal and a lymphoma of the thyroid or lymphoma of the pituitary have all been classified under one grouping of hematolymphoid lesions. So this has saved a considerable amount of space and removed redundancy in the book. As I've already mentioned, the genetic tumor syndromes, specifically as they relate to their presentation within the endocrine organ system. So let's talk about these follicular-derived lesions. And of course, in this case, we're going to talk about papillary thyroid carcinoma. So if you think about papillary thyroid carcinoma, it is a whole group of entities that have a specific and distinct nuclear feature with a variety of different patterns of growth. Two important things, cribriform morular and microscopic carcinoma have been removed from this classification system. So the microscopic tumor category is no longer used, and instead it is just called classical papillary carcinoma. And if you want to give a size, you can say the specific size. So this allows now for the classification of, let's say, a tall cell variant that's 5 millimeters, or a columnar variant that may be 6 or 7 millimeters in size, because we recognize that those tumors, even though they are microscopic, may in fact have a different outcome than the classical papillary carcinoma category that is in a microscopic group. So let me talk about the architectural and cytomorphologic features here for a few moments. Architecturally, if you think about it, lymphovascular invasion or capsule invasion, variable growth patterns, elongated and twisted follicles, psammoma bodies, intratumoral fibrosis, very bright colloid, and of course, crystals or giant cells. So when one thinks about the growth pattern, here you can see that there are bundles of skeletal muscle with the neoplastic proliferation dissecting between them and clearly as an infiltrative component. So the single most important thing about this is, as one looks at the new AJCC8, staging of extrathyroidal extension must be something that is seen either macroscopically while we are grossing the specimen, or documented by the surgeon during surgery or identified during preoperative imaging. So this means that extrathyroidal extension now is a combination of findings. And so if that information is not conveyed to the pathologist, they may misinterpret it. So if you have a 7 millimeter tumor in the AJCC7 that had extrathyroidal extension, it would immediately put it up into the 3B. Whereas now that is not the case unless it is something that was identified preoperatively or during the grossing, which is quite often not the case, especially with microscopic disease. So that's a major improvement in not overstaging the smaller tumor categories. It's important to recognize as well that post-fine needle aspiration artifacts can certainly be seen. This is not equivalent to invasive growth. And when you go and look at it on high power, you can see that there are multinucleated giant cells that can be present. In that example, you can tell that there's plenty of them here, areas of extravasated erythrocytes and an inflammatory response. Another example here where you can see that there is a very abrupt area of transection where the needle went through and then resulted in this proliferation immediately adjacent to it. So fine needle, because it is done in so many instances, is an important thing to recognize in evaluating for capsular or lymphovascular invasion. So this is a nice example of capsular invasion. You can see that there is an abrupt end to it. This happens to be with a elastic stain because that was what was done by the person sending the case, but you can tell that the elastic is completely broken and also confirms that a true capsule is present with a nice bundle of tumor that is expanded into the capsule. Lymphovascular invasion with a tumor embolus present within a vascular-lined space attached to the wall. And then multiple papillary projections that are quite complex, lined by neoplastic cells that have a very complicated architecture and cytomorphology, one of the classic findings for papillary thyroid carcinoma. So here you will see that there are way too many nuclei present in this space. This would be what we recognize as an example of nuclear crowding or overlapping in this instance. So when psammoma bodies are present, they are also quite characteristic. You can tell that there is concentric lamination as the calcium has been deposited. But one of the things that people argue about is location of psammoma bodies. So if I see a psammoma body in a subcapsular sinus of a lymph node, this represents metastatic disease. Because if you look at this psammoma body on electron microscopy, I know, can you imagine going back and doing electron microscopy? But here you will actually see all of the nuclei present that have been degenerated or died. Here is the central lumen of the fibrovascular core with all of these concentric laminations of the calcification. So to me, this means that tumor got there and then was covered by calcification over time. And therefore, psammoma body is just a reflection that there is dead tumor, but that it did get there through the lymphatic or vascular system. Acellular eosinophilic fibrosis like this, often accentuated if you drop the substage condensate, it will be quite brightly refractile. And that finding is more commonly identified in papillary thyroid carcinoma than any of the other lesions in the differential, like adenomatoid nodules. Mummification is something that is not talked about very much, but you can see that there is kind of this infarct appearance where the follicles are still present, but have kind of lost their nuclear detail. This finding is something, again, with a wedge shape out towards the capsule, is not something that I've seen in lesions other than papillary thyroid carcinoma. But again, it's only seen in about 1 to 2%. So when I see it, it's very characteristic, but it's not seen very frequently. Crystalloids can be seen in the lumen. They are kind of non-specific, however, but I will tell you that if I'm looking at a case and I'm struggling with the nuclear features or some of the other areas of histology, if I see a lot of intrafollicular or intraluminal crystalloids, that can help me to decide that probably it's more likely to be seen in a papillary thyroid carcinoma. The same thing with multinucleation. Here you can see multiple nuclei in the lumen. These are actually histiocytic nuclei. They are not nuclei of the tumor itself. They would be positive with CD68, but that kind of giant cell formation in a neoplasm is also quite commonly seen in papillary thyroid carcinoma. Now, again, this is not a specific finding. You can see multinucleated giant cells like this in a variety of other lesions as well, granulomatous thyroiditis or Jacobs thyroiditis, some of the other lesions. So it is not specific, but when I see it in a case that I'm struggling, it certainly gives me some additional support for the interpretation of papillary carcinoma. Let's now talk about the cytomorphonuclear features with enlargement of the cells, high nuclear ratio, overlapping and crowding, irregular placement around the follicles, grooves and folds and irregular contours, intranuclear inclusions, and then of course that characteristic pale chromatin with margination, kind of the orphan Annie nuclei feature. So I've purposely set out the papillary carcinoma for a moment just so that you would get a view of the surrounding tissue. So here you can tell the nuclear size. And then here is the papillary thyroid carcinoma. This is the only papillary carcinoma that was seen in this patient. They happen to have lymph node metastasis. But I think you can see that these nuclei are much larger than these. So one of the things that definitely needs to be considered when you're talking about nuclear size is recognizing that we're looking at a two-dimensional plane of a three-dimensional object, and we kind of project this as being a sphere. So if you think about a nucleus here that is maybe 2 times the radius of what you see over here, you have to really think about the volume of a sphere, where it is 4/3 pi r cubed. So if I were to put this in kind of simple math terms, if the radius was 5 microns, which is about a 10 micron diameter, you have 523 as the number. But if you now increase that to 10, so I've only increased the radius just by one factor, you'll see that it's nearly 8 times the volume of the cell. So even though I'm looking at a two-dimensional object, in my mind, I say, wow, this is 7 or 8 times the size of the adjacent cells in volume. And therefore, when we talk about nuclear enlargement, that is the feature that really needs to be considered. So I do like to think about papillary carcinoma as I do the phases of the moon. We all know that the moon is still there, even though we may not be able to see it, right? So at the beginning, you just have this really thin sliver. And then as you go through the cycles, it becomes a full moon and then goes back to the other side. So if I think about the papillary nuclear features in a single high power field like this, I can see all of those phases of the moon. And if I look at the entire field, you can tell that all of those are presented here. So that is one of the features that is very characteristic for a papillary thyroid carcinoma that you wouldn't otherwise see in other lesions. So it really is a very complex appearance, and not every single nucleus has the same appearance, but overall, I get the sense that all of the phases of the moon are represented. Numerous cytoplasmic folds, intranuclear folds, folding of the nuclear membrane material. So is it real or not? Well, here is electron microscopy. I know the electron microscopy, again, I'm going to show one more, so just prepare yourself. But you will see that this is really a very, very well-developed invagination, and it is a genuine fold that is histologically and seen on EM able to be identified. So it's not just an artifact. This is a genuine groove or folding of the nuclear material. One of the studies by my friend, Dr. Papotti, shows this as a really confocal microscopy, giving a three-dimensional reconstruction. And you can really tell how amazingly complex the nuclear features are of a papillary thyroid carcinoma. Intranuclear cytoplasmic inclusions. Well, you know, I'm highlighting just a few of them here. And since the Olympics are about to begin, I couldn't resist. But if you think about this in context, again, here with the last of my electron microscopy studies, there is a membrane surrounding this, and it is a genuine cytoplasmic organelles present within the space of the nucleus. So it's a genuine intranuclear cytoplasmic inclusion. It is not a fake inclusion. It's not a fixation artifact. This is a genuine finding. And generally, the more cytoplasm you have, the more likely you are to see this. So variants like the tall cell subtype or the columnar subtype, oncocytic pattern, all are tumors that tend to have more intranuclear cytoplasmic inclusions. So now we talk about the very fine, delicate, even nuclear chromatin. And of course, thank goodness there is a stamp for this. I know you didn't think there was, right? But let's look at little orphan Annie. I did not know who she was, right? Because I'm foreign, I'm not from America. And here in 1995, they came out with this stamp and we looked at it and I thought, oh, this is actually fantastic. First of all, we must go to high power because that's what pathologists do. And you will notice that there is margination out towards the periphery with complete cytoplasmic clearing. And it's in both of their eyes, which means it is not just a fixation artifact, it's a genuine finding. So now when you look at these papillary nuclear features, you can see that they really are quite well developed in all of the nuclei. So there are a whole bunch of different molecular techniques that can be used to be able to identify the genetic markers, mRNA gene classifiers, and of course panels. And then of course, when you think about the actual mutation status, you can see that there's quite a remarkable variability, BRAF, RET, and RAS being the most frequently identified. So just in broad strokes, if you think about it, the BRAF, RET, and RAS are more likely to be associated with papillary carcinoma, RAS and PPAR gamma for follicular tumors. And then when you get additional molecular alterations like P53 or beta-catenin and TERT, you get into the poorly differentiated and ultimately going on to anaplastic. So when you think about the activating mutations and gene fusions that you can see in papillary carcinoma, by far and away, BRAF, and whether it's the V600E or K601E, they do account for the vast majority, followed by RAS. And then there are a variety of others. Of course, RET is in there with about 10%, FADA and NTRK mutations, ALK fusions, etc. And of course, TERT promoter mutations can be seen concurrently with any of these other mutations as well. So conceptually, if you think about this, there are actually kind of two major broad families or patterns. So the BRAF type appearance, as you can see from this data from TCGA. And then, of course, here you can see that it is a more RAS-like pattern over here. However, you will notice that each of these other particular mutations generally falls somewhere underneath each of these particular categories to be able to give a broad stroke of appearance to the lesion. So it is usually quite a complicated interrelationship between all of the molecular pathways that are involved in the development of papillary thyroid carcinoma. So while BRAF is the most common, you can see that RET fusions account for about 10 to 15%. Very specific settings, however. You can see that it's much, much more common in radiation-associated groups. So these were patients especially studied after the Chernobyl incident. You can see that they were generally in the pediatric age group where they had an NCOA-A4 RET as the most common fusion. They are much more frequently identified in pediatric patients where it's the CCDC6 as the most frequent. And then, of course, it's also seen in poorly differentiated, primarily because that's where you're talking about papillary thyroid carcinoma developing other hits in the molecular pathway in order to be able to go on to that particular group. So as you know, there are two major pathways, the RET fusion pathway and the RET point mutation. I'm not talking about the RET point mutation ones at all today because that's primarily in medullary thyroid carcinoma, but either sporadic or inherited pattern. But it's really the fusion related. And you can see here that up to about 20% of papillary thyroid carcinoma can have this particular mutation seen within it. There are a variety of different translocation partners that can be seen. It is an extracellular transmembrane and intracellular protein that activates the RAS MAP kinase pathway. Interestingly, the RET fusions were actually originally discovered in papillary thyroid carcinoma, so this is why it has remained near and dear to our hearts. Well, I'm not going to expect you to memorize this, and it's purposely done a little bit small, just to show you that there are a myriad of different RET fusion partners, and they all have alternative names and specific domains, and then the specific neoplastic category in which they're identified. So these are the most common ones that we come across, and you can see that the CCDC6, the NCOA, the PR carrier, as well as the TRIM, whether it's 24 or 33, are most frequently identified, but still the most common are by far and away the CCDC6 as well as the NCOA-A4. And in this case, you can tell that they are specifically associated with various entities such as the diffuse sclerosing pattern that I just showed. Well, a number of immunohistochemical markers can be done, and you can see that the RET, RAS, and BRAF IHC are included in this. But let me just show you that, when you think about papillary thyroid carcinoma, right, this is classical papillary, so there really isn't a reason to do immunophenotype. So it's more frequently done in the follicular patterned tumors. But in general, thyroglobulin is going to be positive in the tumors, TTF1 is going to be positive in the tumor, and then, of course, CK19, HBME1, galectin-3, and even ubiquitin is highlighted specifically within the intranuclear cytoplasmic inclusion component because it's a concentration from the cytoplasm. So I will say, when you think about all of the molecular mutations that we have going on in papillary thyroid carcinoma, and I'm just highlighting some of them here, where you can see that there are a whole host of different ones. Well, I'm still waiting for papillarin. This is the one that I would like someone to develop that is unique specifically to papillary thyroid carcinoma, no matter what the pattern, and that is the name I would like to see used. Clearly, it is not yet developed and not yet out there, but it is what I am hoping that someone will one day identify. So I'm going to put up 8 pictures of some of the glitterati in the music, movie, and acting industry, but then I'm going to change it very quickly, and you'll see that I've actually put my own face into each of these, but you still can see that that original actor's appearance is there. So what I would like this to represent is actually papillary thyroid carcinoma has a lot of faces. It's still one entity that is papillary carcinoma, but just recognize that it can be seen in a wide variety of different cases. So what I would like to end with is just showing one of the most important characteristics for papillary thyroid carcinoma, irrespective of the type of variant that you see, and that is lymphovascular invasion. So it is one of the things that I really like to stress when I think about this tumor. So first of all, you can see absent lymphovascular invasion. First of all, there are not a lot of cases, right? So the classical type, not a lot of the tumors had absent in lymphovascular invasion. However, in the microscopic and the follicular variant, either encapsulated or invasive type, you can tell that they very frequently will lack any evidence of invasion. But when there is no lymphovascular invasion, there is zero chance of having a patient with disease or developing metastatic disease having some sort of recurrence. So it really is a very significant finding. Whereas when you go to lymphovascular invasion being identified, now you will see that 20 out of the 175 cases, or 11%, had the feature, and therefore there is going to be an alteration in how the patients do. Still, you can see that it is not a huge difference in overall outcome, but clearly there is a statistically significant variation in what happens with these patients. So I think if one follows the ATA guidelines, and I'm sure that they will have another one coming up soon, that there is a risk stratification model that can be utilized in order to be able to come up with the accurate criteria. So with that in mind, I do hope that I've been able to shed a little bit of light on the world of thyroid tumors, and specifically of papillary thyroid carcinoma, and I'm happy to take any questions at this time. I hope you have a great day.